I'm a health disparities researcher and a faculty member at NYU School of Medicine in the Department of Population Health. And I'm going to be basically sharing our experience with you today in terms of overcoming ethnic disparities in diabetes with some examples from our research and work in the Asian American community in New York City. So just an overview of what I'm going to be talking about today. And I'm really going to start with some background on the Asian American community and some of the unique health disparities faced by this population. So this is just a graphic of Asian Americans in the United States, and I like to start with this just to give everyone a sense that Asians are everywhere. You know, I think there's a sense that they're really only in New York and California, and they are certainly concentrated there, but there are growing pockets across the country and concentrations really across the country. So their health concerns are going to be important to the healthcare context across the U.S. I think the key feature of the Asian American community that's important in terms of understanding how to advance their health is that this is a tremendously diverse community. It represents over 16 different ethnic groups, and within those ethnic groups, a numerous number of nationalities, languages, religious groups, etc. This is true sociodemographically as well. There's, you know, a sort of common notion of the idea of the Asian American community as a model minority. But you know, increasingly we know that that's not true. This is a bimodal community in terms of socioeconomic characteristics. So there are high rates of poverty, limited English proficiency, and other sociodemographic characteristics across the subgroups. And this just goes towards that in terms of looking at Asian Americans as well as Native Hawaiians and Pacific Islanders living in poverty. Census data and other data do demonstrate that the percentage of this population that's living in poverty is projected to increase over the next 50 years. In New York City, where I do most of my work, the sociodemographic characteristics of Asian Americans are reflective of some of these things that I talked about. So for example, 1 in 4 Asian Americans live in poverty. The fastest growing senior citizen population in New York City is the Asian American population, and they have the highest poverty rate in the city. 1 in 4 Asian American students do not graduate in time or at all. And really another key feature and issue in this population are high rates of limited English proficiency, which also vary across the subgroups. In terms of health disparities, you know, I was listening in on the peer exchange panel earlier, and you know, the diabetes epidemic is very squarely focused on Asia. You know, it's well known, India and China, the highest rates of diabetes. So it's surprising that, you know, the diabetes disparities among Asian Americans in the U.S. are not as widely discussed or documented, and part of that is a data issue. You know, data is often aggregated across Asian Americans and masks some of the disparities that they face. So the CDC put out this report in 2008 aggregating data across several years to show some of the disparities across ethnic groups, and you can see the pink bars are diabetes. I know it's a little hard to see, but you can see that there are variation in rates and quite high rates in diabetes among particular groups such as the Filipino population as well as the South Asian population. Those trends are also seen in New York City, although again the data doesn't always demonstrate that when it's put out by the City Health Department or in reports. So for example, the New York City Community Health Survey data found that rates of diabetes among the Asian American community were around 13%, a little bit higher than the overall population, but still lower than some of the other racial and ethnic minority groups. We then took that data from the City Department of Health, aggregated it across years to be able to look at differences across subgroups, and you see really astounding differences and very high rates in terms of when you look at diabetes across various subgroups. So for example, again, in the Asian community, the Filipino community, the South Asian community and the Filipino community. We tried to look at this again using another cross-sectional telephone-based random digit dial data set, and we're able to confirm these results. These findings are published in Diabetes Care, and we found again that when you look at the rate of diabetes across Asians as a group, it really misrepresents what's going on across subgroups. So how do we address this? This is what we're here to discuss today, and what I'm going to share with you is really how our work is grounded in community-based and community-engaged approaches to addressing diabetes. In particular, I'm going to talk about community-based participatory research and the community health worker model as a promising approach for addressing diabetes disparities in this population as well as other racial and ethnic minority communities. So our work is situated out of 2 research centers of excellence that are based at NYU School of Medicine and funded by the NIH and CDC. We have a CDC-funded Prevention Research Center based at NYU, as well as this NIH-funded P60 Health Disparities Center of Excellence that are focused on addressing health disparities in Asian American communities. As part of the work that we do, we have a guiding framework of using community-based participatory research to really implement and engage in the research and intervention work that we do. So for those of you that are unfamiliar with this framework, the fundamental principles of community-based participatory research are that it really involves an active collaboration between community and between academia. And community, I think, can be very broadly conceived, and community is comprised of many different players, including, the healthcare system, payer organizations, community groups, et cetera. CBPR facilitates co-learning, really ensures that research is community-driven, disseminates research in ways that are useful for key stakeholders, and ensures research that is culturally relevant as well as linguistically relevant. So the approach that we've spent a lot of time evaluating is looking at the use of community health workers to improve healthcare management and prevention. And most of my work focuses on diabetes prevention and management. So community health workers are frontline public health professionals who have an unusually close understanding of the communities they serve, and that understanding can come through a shared ethnicity, culture, language, or life experiences. CHWs are often referred to through different terms: promotoras, outreach workers, community health representatives, patient navigators. There's sort of a wide breadth of different terms that are used to describe a similar type of function. Some key characteristics of what a CHW approach does is that it improves access to healthcare resources, it improves the quality and cultural appropriateness of service delivery, helps integrate disease and prevention and management into the daily lives of community members that are served, organizes communities to improve not only individual level health, but environmental, physical, and social well-being. It negotiates cultural and linguistic barriers to health and helps others become active participants in their own health. So this idea of really increasing self-efficacy. To me, the best metaphor for what a CHW is and what they do is they really serve as a bridge between communities and systems, not just healthcare systems, but other systems that influence the receipt of healthcare and living of healthy lives. So why CHWs? Why do we focus on this in our work at our center? There's a burgeoning literature demonstrating the effectiveness of CHWs across many different conditions, including diabetes, cardiovascular disease, and other CVT risk factors. It's a large workforce, and with PPACA, there are sort of unprecedented opportunities for the integration of CHWs into medical teams and into healthcare systems. Some of the key characteristics of CHWs are that they have a very close connection to community. They're honest, respectful, trustworthy, open-minded, non-judgmental, persistent and resourceful. I think, as I share some of the findings from our work, you'll see how this comes across. And this idea that they're empathetic, caring, and compassionate. And I think all of that rooted in this context of being very closely connected to the communities that they work with are a key aspect of why they are successful or doing what they do. CHW role, there's sort of a wide range of what CHWs do. This is an example of what CHWs do on some of the work on some of our research studies, as well as CHWs in other contexts. But they, range anywhere from engaging in data collection, facilitating enrollment, providing linkages to healthcare systems and providers, advocacy, community organizing, and referrals to other types of social services. In terms of training, we've identified some core competencies that are really essential for the training of CHWs, and this is, I think, a challenge and an issue with the CHW workforce is that there isn't sort of a national standardized accreditation process. And these are some of the core competencies that we've identified are critical for CHWs and which all of our CHWs who have engaged in our research studies have been trained in. It includes, understanding the role of CHWs, communication and interpersonal skills, some clinical training skills, health promotion training, et cetera. Okay, so what I'm going to do is sort of give you an overview of 3 different studies that we have ongoing that use a CHW as well as CBPR approach, and then I'm going to focus in on a case study of one of our diabetes management studies just to give you a better in-depth sense of what some of our findings are, and we'll go from there. So we currently have 3 community health worker interventions that are based out of our center, Project Aspire, the DREAM Project, and Project RICE. Each of these focuses on a different Asian American community and has a slightly different focus area. So Project Aspire is a community health worker intervention aimed at improving hypertension management in the Filipino community. The DREAM Project is focused on diabetes management in the Bangladeshi community. And the RICE Project is a diabetes prevention, community health worker-led intervention in the South Asian and Korean communities. I'm going to talk about what some of the common elements are with our projects to give you a sense of how we really try to root our research in these approaches. In terms of our CBPR framework, all of our research is guided by a community coalition that consists of sort of numerous stakeholders, including representatives from social service agency, community groups, religious organizations, as well as healthcare providers, or independent healthcare providers that provide services to the community, and our academic partners. Our coalitions meet it varies by project, on anywhere from a monthly to bi-monthly basis, and they've really been involved since the inception of each of the projects to ensure that they're engaged throughout the research process. Each project really tailored existing curriculum for use in their target communities, and I'll talk a little bit more specifically about that with a case study. And the coalitions really place particular importance on the cultural relevancy of concepts and linguistic concordance. So, I shared with you earlier, limited English proficiency is a huge issue in the Asian population. So ensuring that our interventions and what's delivered is linguistically tailored and appropriate was critical. Each of our projects really employs rigorous evaluation and feedback to ensure, that we're doing what we sought out to do. In terms of the curriculum, each of the community health worker interventions is adapted from existing validated curriculum. So Project Aspire, for example, is drawn from a National Health Lung Blood Institute funded curriculum entitled Healthy Heart, Healthy Family that was developed for the African American population. We actually worked with NHLBI to then tailor it for the Filipino community. The DREAM Project drew some elements from that and was also drew from the Power to Prevent and a few other diabetes management curriculums. And Project RICE, our diabetes prevention project, was largely drawn from DPP. And we also worked with a researcher based at Johns Hopkins who had engaged in a diabetes management study in the Korean community, so brought in some elements from her work. In terms of the intervention design, it varies slightly across the studies, but they each are randomized controlled trials with treatment and control arms. Individuals are randomized into each of those arms. And there is follow-up and data collection at baseline, some midpoint, and then a follow-up point in each of the studies. The intervention duration ranges from 4 months to 6 months across the studies. So I mentioned that, we really the coalition and our projects really give a lot of importance to culturally appropriate research methods, but we do have, as an overall goal, we really do want to understand what the impact of community health workers can be across communities and populations as well. So for that reason, a lot of our data collection is standardized across projects, but tailored in order to address some of the cultural issues among each group. And these are just some of the examples of some of our cultural tailoring. I'm just going to skip that. Okay, so I'm going to go on now to talk about findings from one of our specific studies, which is our diabetes management study, and that is our DREAM project. DREAM stands for Diabetes Research, Education, in action among minorities. And I'll start off with just a little bit of background and context. This project focuses on the Bangladeshi population in New York City. This population in New York City is about estimated at about 64,000, although the estimates range anywhere from about 64,000 to upwards of 150,000. It's a very high-need population in the sense that there's very high rates of limited English proficiency, over half of the population. About a third of the community lives in poverty. The majority of the population is foreign-born. And it's also the fastest-growing Asian American subgroup, both in New York City as well as nationally. In addition to that, Bangladesh is one of the top 10 countries estimated to have the highest cases of diabetes worldwide by 2030. So we also know that prevalence of diabetes is really quickly growing in the home country. One of the things we did to really guide the development of the intervention in conjunction with our community partners was to employ a mixed methods formative evaluation to guide the development of the intervention, the curriculum, and really, the research process for the entire study. So we did a series of focus groups coupled with a survey in the Bangladeshi community in 2009. And some of I'm not going to read through all of this, but those focus groups really helped to inform the development of the intervention in terms of ensuring its cultural and linguistic relevancy, as well as thinking through some of the socio-demographic characteristics and social issues that are faced by immigrant communities in New York City that would impact the intervention. So for example, Bangladeshi men are really concentrated in low-wage sectors of the workforce, such as taxi driving, restaurant work, vendors, things like that. And so thinking about how we could reach those men, how they'd be able to participate in the intervention, how food habits have changed after coming here to the U.S. One of the things we found is that there's this sense that people come here from other countries, they have great diets, and then they just eat a bunch of American fast food, and that's what's causing all the diabetes. What we found is that people very strongly hold on to their home country diets here, but the difference, that a lot of participants mentioned in the focus groups was that sort of this idea of almost an overabundance of certain foods here, like high-fat meats, and other types of foods that they weren't necessarily cooking at home. And so, thinking about how to address that through our intervention and curriculum. And then I think this last quote really summarized really well for this community what was happening, and that's one of our male participants who said, "We know what has to be done, but we don't know how to do it." And so that was really a focus of developing this intervention. So this was our goal, to develop, implement, and test the efficacy of a community health worker-led intervention to improve diabetes control and management in this population. Our study design, I mentioned it is a randomized controlled trial. Our eligibility criteria are as follows: Bangladeshi individuals who have an A1C of over 6.5. In terms of the design, individuals randomized to the treatment group receive 5 protocolized group sessions and 2 one-on-one follow-up visits from the community health worker that usually are conducted in the home, but can be conducted in other settings as well. And then phone calls as needed, follow-up phone calls. The control group receives the first introductory session and then is invited to participate in the full intervention after they've served as a control. And that was something that was really emphasized by our coalition, something that they really felt was important. We engage in both quantitative and qualitative data collection, quantitative data at baseline, 3 months and 6 months, and ongoing qualitative process data to assess the impact of the intervention. So our community health workers are hired directly by NYU School of Medicine. And people often ask, who are these CHWs? How do you find them? Who are they? Our coalition was really instrumental in that, in terms of helping us very much tap into grassroots leaders in the community. So 2 of our 3 community health workers had solid backgrounds in community organizing, actually labor organizing in New York City. And another one of our community health workers was involved in student organizing. He was very involved in some of the sports leagues, Bangladeshi sports leagues in New York City. And so they were very much rooted to and connected in the community. And our CHWs say it all the time, it sounds like they're bragging when they say it, but they don't mean it this way, that, yeah, everybody knows us, they all know us out there, and so it really facilitates the process of implementing the intervention. We partner with hospital and clinic sites for referrals and care coordination with the intervention, and we use a very sort of diverse, multi-pronged recruitment strategies. We do some tabling in the clinic and work directly with the clinic to enroll individuals. But we also work very closely with the ethnic media, and it's certainly a lesson learned in terms of working with immigrant communities that leveraging these types of resources like ethnic media are critical. And then we do, especially because we conduct this intervention in rounds, a lot of snowball referrals and from past participants. So our analysis, we are engaging in both quantitative and qualitative analysis. I'm not going to get too much into this. I'm just going to share some of our preliminary findings so far. And they are preliminary. The intervention is ongoing right now, but just to give you a flavor. So this gives you a sense of our recruitment and retention. We've had pretty high retention in the program, about 88% of our treatment group participants. It's been a little bit more challenging with the control group participants for obvious reasons. About 75% of control group participants have been retained. And then just in terms of what they look like at baseline, in terms of demographic characteristics, we were happy to see both that our treatment and control arms are very comparable, and that they're also very reflective of the Bangladeshi population overall in New York City demographically in terms of gender, in terms of age, in terms of years spent in the U.S. This is very reflective of this population, as well as in terms of limited English proficiency. So these are some of our preliminary results in terms of clinical outcomes. The points highlighted in red are where we've seen some statistically significant changes in weight, in BMI, and in systolic blood pressure. We've seen only modest reductions in A1C, and we think part of this is because our enrollment criteria is fairly liberal in that we are enrolling individuals with an A1C of over 6.5. This was, again, something that was very much driven by our community coalition, who felt like because there really had never been a resource like this for the community, it was important to open it up to as many people as possible. We've seen really great changes in terms of behavior change and some other areas. And one area in particular is physical activity. What we found in this population is that there was really low rates of physical activity at the beginning. And a lot of participants who just never even thought of it. It hadn't even occurred to them to engage in physical activity. And so that's really a central focus of some of our intervention components. And we do see great improvements in terms of self-reported engagement in physical activity in both the treatment and control group. Another issue that, again, this was driven by our development of the intervention. We knew that rice is a staple food in this community. And our coalition also advised us that, going to participants and telling them they had to change their diet and change their cultural food wasn't going to be effective or work. And so, instead of, asking participants to not eat rice, the idea of changing to brown rice or mixing rices was introduced, and we've seen some great improvements in this area, as well as food behaviors such as better portion control, more confidence in preparing and buying healthy foods. Participants report less barriers in terms of engaging in healthful eating, and also more confidence in terms of engaging in healthy eating. I know I'm almost out of time, so I just want to share a couple more things. We've also seen, I know our next speaker is going to talk about medication adherence. This is another area where we've seen improvements in terms of the intervention group. And then self-efficacy. This is an area that was really important for us to include, because the reality of the population that we're dealing with, particularly the female participants, are that, there's very high rates of limited English proficiency. There's oftentimes many restrictions by the family in terms of traveling, by themselves, on the subway, going outside of their neighborhood. And so, really enhancing self-efficacy was an important part of the intervention, and we've seen some great changes. We're also supplementing our quantitative data with qualitative case studies, and this is one I'd like to share just to give you a sense of the impact of the intervention. And this is drawn from some of the case notes from our CHW's one-on-one visits with participants. So one of our female participants, who's 52 years old, joined the DREAM Project in 2011, initially felt uncomfortable traveling to and from the hospital by herself. The CHW noted language is always a problem and an issue, and she needs help with getting to appointments and going to the doctor by herself. She always needs help to go to the doctor and can't travel alone. She was really empowered by the CHW to learn how to travel via public transportation and take charge of her own health. And the CHW writes, she could never go without assistance, but now she's capable to go to the hospital and also visit her other relatives who were not encouraging of her to engage and travel on her own. They said she'd be lost. Right now she has confidence that even if she is lost, she can find the place as long as she has an address. And since 2011, she's referred family and friends and other community members to the project and remains an active volunteer. So I'm gonna skip over this and just talk a little bit about where I see the future in terms of community health worker research and policy. As I mentioned, there are some really concrete opportunities for CHW integration into ACA with patient-centered medical homes, health homes, maternal, infant, early childhood homes, the health benefit exchange. These can include, outreach and engagement, care delivery, care coordination, and increasingly being integrated with HIT. And so I think these are important things for us to consider if we want to advance the community health worker model. And kind of our future research, and I think particularly relevant to this audience, is really thinking about how can we bring together all the various stakeholders, providers, payers, as well as communities, and can we think about CHWs being integrated with some of the provider level initiatives and payer level initiatives that are going on. So this is a new study that we'll be engaging in. It just got funded, so brand new, and this is specifically around advancing Million Hearts goals. So in terms of my conclusions, community health workers really provide a critical link between communities and health systems and can help to improve health behaviors, diabetes knowledge and management. Diabetes prevention, I didn't talk about my other diabetes prevention study, but we've seen some great improvements from that study as well as self-efficacy for vulnerable populations. It's very much a community-engaged, tailored approach, and I think we're here today talking about patient-centered approaches, and I think there's a relevance there. The integration of CHWs into healthcare teams and fostering their acceptance by providers and systems will be essential to their effectiveness, and I think that's really critical. Part of that is having some tough, kind of discussions around accreditation. And other issues for CHWs. And then, to what we do, I'm a researcher, so, continual, comprehensive, and rigorous evaluation is really going to be essential to advancing the effectiveness of this model. So again, thank you, and, I look forward to our discussion and the rest of the panel.